Good morning. Whenever I hear that introduction, I'm reminded of something that someone once said about me, which is they were quoting my wife, who said that on my good days, I sound somewhat like a Renaissance man, but on my bad days, I'm more of a dilettante. You'll get to decide. Someone also once said he sounds like somebody who can't keep a job, and that's also true. So I deliberately included the fact that I was a pediatrician on these slides. How many here work with children in their research capacities? Thank you. How many work solely with children? Thank you very much. So my interest in pediatric research started early when I realized that we didn't know very much about children from a logical way by doing clinical research. When I started in my medical career, research on children was considered unethical. Things have changed. So our disclaimer and conflict of interest for NIH is becoming as long as IRB consent forms. The presentation does not endorse or recommend, I can see it here, any commercial products, processes, or services. The views and opinion of the speaker are my own and do not necessarily reflect those of the U.S. government. And these statements may not be used for advertising or product endorsement purposes. So here's the outline of my presentation. We're going to talk about it. We're going to give a brief introduction to research, the introduction of bias. We are all biased. We're going to go through some examples of things that we knew that were lies. We're going to talk about the grade system, which is an organized and systematic way of looking at data and trying to create from it information. And there'll be a one-slide take-home message for you. So research has evolved, and you can decide when you think then was, but then was small scale, and now research is done on an industrial level. It was potentially therapeutic, and now we do studies not so much to help people get better, but to increase our storehouse of knowledge, basic science. In the beginning, we did research on ourselves, our friends, and our families, and we've expanded that to patients, prisoners, and orphans. So research has come a long way. So how have we evolved in our data collection techniques? We started out with personal experience. Never underestimate the power of personal experience. How many people took an aspirin this morning before they came here? Not for the headache I'm about to induce, but for your cardiac disease. So that occurred because a hospital administrator went to a rheumatologist in his community, wanted to know why he wasn't admitting to the hospital as often as the other internists. It turned out that his practice had far fewer heart attacks than others. The difference was that he used aspirin to treat all his people with rheumatoid arthritis and had a lower incidence of heart disease. That was confirmed later on with clinical trials. Expert opinion that's when you get people like myself who get up here and talk as if they're experts. And I definitely have opinions. They became developed into small case series and natural history studies, large case histories and natural history studies. We then started to do cohort studies where we compared groups. And we finally ended up with randomized trials where we took the same group of people to try to reduce the number of variables and then try out our interventions. Clinicians, in their case series presentations, talk about in my experience. As a private practitioner for 20 years, I had in my experience, which said that I had seen one case. If I said time and time again, it meant I had seen two. And if it's been shown over and over and over again, I saw 3 cases that were therapeutic successes. So how many people here think that they're biased? How many people here think they're not biased? Well, I'm glad to see that. The introduction of replay into Major League Baseball, the sport of my particular choice, has truly demonstrated how biased I have been, because I knew that every call that went against the Baltimore Orioles was a mistake. Now, unfortunately, I've been shown that it's not a mistake, and far more often than I would have ever given them credit, the umpires are correct. So bias comes from a lot of different places, but I like to start out with Plato's Allegory of the cave. For those of you who were bored to death in philosophy class, I apologize. But for Plato's Allegory of the cave, it starts out that you're taken at birth and you are chained to a step where all you can see is the cave wall. It's your only information. And then people behind a stone wall, so you can't see the people, hold up objects in front of a light source, in this case a fire, and throw images onto the wall. Fantastic images, but they are your only reality. You begin to believe that they are real. Much like PowerPoint, now that I think about it. Okay. The prisoners eventually break free and get to see behind the wall and realize that the shadows were created by objects, and they move closer and closer to the cave entrance where they gain both knowledge of what the world is really like because they get to see the objects and not the images of the objects. And then when they leave the cave entrance, they have gained wisdom. And the philosophers of this time were the scientists of today. They were trying to ask the big questions to get the big answers. So you have to sort of recognize your limitations. There's a really small circle of what you actually know. It is surrounded by a slightly larger circle of what you think you know. An even larger circle of what you know you don't know, and then by far the largest universe is what you don't know that you don't know. Every time we have a clinical trial that's done twice and gets two different responses, people say, oh, somebody did it wrong. And I say, no, we didn't know what we didn't know, and there's a variable out there that we're not yet measuring. The first people were honest. The second group were honest, assuming that they are honest. But there's something else going on that we don't know. And if you get confusing results, it's wonderful for generating hypothesis, but it's not so wonderful at generating information. So don't be fooled by your limitations. Benjamin Disraeli, among many others, have been credited with the sense there are lies, damn lies, and statistics. I was fortunate enough to have several statistics courses, one in physics and two in the social sciences. And Dave Mellitz, my first statistics professor in the social sciences, said to me, what's the most important statistical test? And so we put out the chi-square, other tests came to the t-test came up, analysis of variance came up, and he said, no, the most important statistic is the interocular statistic. If it hits you between the eyes as important, it's important. If you got to prove it with math, maybe not so much. So if you don't read the newspaper, you're uninformed. If you do read the newspaper, you're misinformed. I feel the same way about scientific literature. I go from uninformed to potentially misinformed. Those who cannot remember the past are condemned to repeat it, which gets taken up by Clarence Darrow as history repeats itself, and that's one of the things that's really wrong with history. So how do we go from data to knowledge? Data is defined as a set of discrete, objective facts or values that does not have any attached meaning or context. You change data into information, and here's where you introduce bias. Data that has been organized and processed. Who organizes it and processes it? Human beings. And are able to instruct or inform other users. So you organize the data. You take the data that you like, that fits your hypothesis, and you organize it in a way that supports your hypothesis. If you can get from information to knowledge, which is the sum of what is known and is integrated and applied, gained through further education, practical experience, and training. But bias comes in very early in the stuff that we look at, in the information that we think we have, and the knowledge that we think we have, because it's introduced when you take this step, this jump from the things you measure to what you think they're saying to you. My background is in physics, so you have to have at least one equation. U equals V times R divided by W. Usefulness of the information is dependent upon the validity of the information times the relevance divided by the work it takes to find that information. And you all have a way of doing this in your own head because you all have a way where you go, you all have places where you go to get information. Some of you use evidence-based textbooks. Some use systematic reviews, portable summaries, drug reference handbooks. Some of you go to colleagues, practice guidelines. And sometimes the relevance is high, but the validity is low. Sometimes the relevance is high, the work is low. And as you go down, you have different ways of looking at how you go for information. At the very bottom of this slide, I have mass media and the internet now. And by the internet now, I don't mean the systematic databases that are on the internet, but I mean when you type in Lyme disease and the first thing that comes up is the first thing you click on. Please be careful, unless you're looking for things to put in your gin and tonics. So one more time, going through the evolution of data to knowledge. Data is composed of discrete elements that are categorized, calculable. You collate them, you quantify them, and you collect them. In information, you contextualize this data. You compare data to other data that you might have. You converse, you connect. Most importantly, you filter, you prioritize, and you order, all based on your experiences, knowledge, and bias, or lack thereof. And you order and frame. In knowledge, which is a little bit higher than information, you structure, you interpret, you evaluate the value of the information, and you deconstruct the information that you're given. People who are knowledgeable, and I suspect you all have someone you go to for knowledge, what they do is they can sort through all the information that you have. So you get a feeling for not just the information that's out there, but where it's rank ordered in the universe. There are very few wise people, and there are very few wise clinicians, but these people actually have the ability to apply knowledge through the filter of their experience. So we have both conscious and unconscious biases. The conscious ones are pretty easy. I support the Baltimore Orioles. The umpires are always wrong when they call plays against the Baltimore Orioles. That's a pretty conscious bias. I probably have hundreds of unconscious biases. For a while, people were trying to get around this biases. One of the systems that were being used were things called word clouds, where you would put up the word clouds, you would have people answer a set of questions about topics, and they would then create the size of the answers by the responses by the participants. But everybody just looked at that slide, and they picked out a single word. I'm not going to ask you what that word is. Another word cloud, because you have emotional attachment to some words. Some people may see molecular, some people may see epidemiologic, some people may see genetic. Well, the genetic is the largest. There are those of us who have color issues. We can't see certain colors because of our genetic makeup. And some letters, some words actually disappear, and you can see open spaces, even though it's supposed to be a way of doing this. The structure of the organization, not only the size of the word, but where it's placed in the diagram and its orthogonal relationship, whether it's lateral, the way you're used to reading, or vertical, makes a difference on how you see the particular piece of information. Okay, so you've looked at this. What did you see? We saw some fish. Some people saw fish. Okay, how many people saw fish? How many people saw birds? How many people saw fish in two colors? Excellent. How many people saw birds in two colors? All right. Can we go back? Okay. Now that you know what you're looking for, you can see that there are both fish and birds in two different colors. But we're humans, and when we look at facts, we look at them with our biases or our preferences or our abilities to move forward. I'm going to give some examples of things that we know or we knew that we now know we don't know. Let's start with leprosy, one of the most feared diseases in human history. And what did we know? We knew that leprosy is the result of sins. And why did we know that? It was because fathers and their children often had it, and mothers and their children often had it together. Family groups had it. So they must be sinners. And we knew also that isolation was the best treatment for all of these people, so we put them in leper colonies, of which there are still 2 in the United States. Now what do we know? Leprosy is caused by a bacterium, the Mycobacterium leprae. The mechanism for infection is still not understood, but it is not highly contagious, and the incubation period is as long as 2 to 8 years in endemic areas. One of the reasons I decided to specialize my field of interest in infectious disease was the following fact. 95% of adults are naturally immune to leprosy. You need to have 2 doses of consecutive genes in a very uncommon allele structure to be susceptible to leprosy. So 95% of the people in this room are genetically incapable of getting it. I wonder how many other infectious diseases are caused by genetic susceptibility. Estrogen prevents heart attacks. How many people went to medical school or nursing school when this was a true statement? Okay, everybody with gray hair should put up their hands as yes. This was a case of logic and not data. Estrogen prevented heart attacks. There was a fact, I'm sorry, not logic, but there was a fact. Young women have fewer heart attacks than young men. That was a fact. It also was a fact that young women have more estrogen than young men. And so the logical conclusion of that was that high levels of estrogen are protective of the cardiovascular system. And we believed that. We didn't actually do much with it, but we believed it. But then what happened was we started giving hormonal replacement therapy to women who had gone through menopause. And hormonal replacement therapy is associated with an increased risk of stroke, stroke severity, and venous thromboembolization, but not coronary heart disease. So it didn't protect you from coronary heart disease, didn't make it any worse either, but it made a lot of the other vascular consequences much, much greater. Although most trials studied older patients, increase was not related to age. Combined HRT increases the risk of venous thromboembolism compared with estrogen monotherapy. So we knew for a fact that estrogen prevented heart attacks right up until the fact that we had data that it did not. Stress causes ulcers. In medical school, the Billroth 1 was the most common medical procedure done in the United States. It was an operation where you took out a piece of the stomach or the duodenum to take care of an ulcer disease. Post-World War II, there was an increasing U.S. incidence of peptic and duodenal ulcers. There was also an increase in smoking, alcohol consumption, and modern life was considered more stressful than other lives. So the conclusion was that smoking, alcohol consumption, and modern life stress led to increased ulcers. And that led a lot of people to have a lot of stress reduction therapy, alcohol avoidance, which is probably good on a couple of levels, and smoking cessation. But despite all of those things, ulcers did not disappear. We now have data that ulcers are an infectious disease, not a lifestyle disease. The bacterium Helicobacter pylori is linked to the development of peptic ulcer disease, gastric malignancies, and dyspeptic syndromes. And H. pylori is present in more than 90% of duodenal ulcers and about 80% of stomach ulcers. So for those of you who have stomach ulcers, you now get a 6-week course of antibiotics and you're cured. One of the most amazing slides, which I didn't include in this desk, was the incidence of ulcer disease comparing to the use of antibiotics in the United States. Ulcer disease started to fall before we understood what was causing it, but it was inversely proportional to how much antibiotic was used in the United States. So as the amount of antibiotic use went up, the amount of ulcer disease went down. We were treating ulcer disease without being aware of it. Eating fat makes you fat and leads to heart disease. This is one of my favorite. This is one of the most egregious examples of scientific fraud. We all know that you are what you eat. We all know that fat is calorically dense. We all know that fat is implicated in heart disease through the mechanism of atherosclerosis. So the biases that we had was that fat makes you fat and fat leads to heart disease. And it was based on the Keys 7-country study. It showed a curvilinear relationship between the percentage of fat intake of the total caloric intake to the mortality of heart disease in 6 of 7 countries. The problem was that Dr. Keys had collected data on 22 countries and chose to present the 6 out of 7, didn't want to make it look too good, so he only presented 6 out of 7 to prove his hypothesis. So there's now been a meta-analysis of prospective epidemiological studies that show there's no significant evidence concluding that dietary saturated fat is associated with an increased risk of coronary heart disease or cardiovascular disease. So fat is now good for you again. Congratulations. Please don't eat too much of the bacon at the break. But there's a new logic developing, which I will ask you to pay attention to, is that carbohydrates cause diabetes. Boy, is that logical. You eat a lot of carbohydrates, you trigger a lot of insulin, you wear out your pancreas, you gain a lot of calories. It makes so much sense. I have no idea if it's true or not, but I'm going to hear a lot about that, I think, over the next couple of years. Denis-Browne splints. So the fact is that internal tibial torsion was a twisting of the tibia. Logic, exerting a correcting force using a splint or brace would correct the twisting. And the generalized conclusion is force works for both orthodontia, scoliosis, and torsion. Here's probably one of the most famous examples of somebody getting rid of their Denis-Browne splints. One of my favorite movies as well. So this is Forrest Gump running, and he is in Denis-Browne splints, or was put in them because he had internal tibial torsion. In 1991, there was a prospective randomized controlled study that showed that the Denis-Browne splints did work very well. However, doing nothing worked equally well. Since 1991, many other splints have been designed to treat this condition, but no non-surgical treatment has been shown to be any more effective than doing nothing at all for young children with uncomplicated tibial torsion. I knew for a fact when I was a young pediatrician that Denis-Browne splints were the treatment for tibial torsion, and I would wonder how many people I have scarred for life for that. Bad air causes infections. Logic. Facts. People who live near swamps, standing water, and refuse piles have more infectious diseases. True. Something in the air increased the chances of infection. So the conclusion was that bad air causes diseases. It developed into the miasma theory. Diseases such as cholera, malaria, yellow fever, or the Black Death were caused by miasma, a noxious form of bad air also known as the night air. The theory held that the origin of epidemics was due to a miasma emanated from rotting organic matter. And they almost got this right. So here's a cholera epidemic also put down to bad air. So since we're talking about human subject protections, I had to talk about one of the earliest clinical trials, not the earliest, but one of the earliest recorded clinical trials. The earliest one I can find is actually done by a British surgeon on a ship who showed that limes prevented scurvy, but this wasn't far behind this. So Walter Reed performed a clinical trial to see if it was bad air or mosquitoes that carried yellow fever. He filled a tent with bad air, an infectious item, and he had a tent in a mosquito-filled area, and only individuals exposed to the mosquitoes became ill. And in 2016, with our knowledge about vectors, we know that vectors carry diseases, and it's the mosquitoes that carry diseases, a lot of diseases that are not so good to men. This is one of the first clinical trials that used an informed consent. So you got paid for your participation, $100 for participation, $200 if you died. It was going to be paid in gold, and you could be paid to your things. So in the IRB world, there's inducement and coercion. Coercion is getting people to do something because they're fearful, and inducement is getting them to do something because they lust after the reward. $100 was equal to 6 months of pay for soldiers at this particular time. I will ask your IRBs to consider whether that's inducement or not. The only female volunteer for this entire series of studies by Walter Reed was a nurse named Clara Moss, and she died of yellow fever. And the public outcry against that ended challenge studies, human challenge studies, in yellow fever for about 90 years. And here's a copy excerpted from Walter's informed consent. And the ... that are there are actually a fairly short series of sentences, but it basically says, the undersigned understands that he endangers his life to a certain extent, but it being entirely impossible for him to avoid the infection during his stay on this island, he prefers the chance of contracting it intentionally in the belief that he will receive from the commission of the greatest care and the most skilled medical service. Walter Reed signed this on November 1st, 2016, and that sentence is about as long as most sentences that I presently see in our IRBs that are supposedly clearly written. I want to talk to you now about the grade system. If we're going to reduce bias, which is the goal of science to some degree, or one of the goals of science, you need to protect against errors. You need to resolve disagreements in how you look at things. You need to facilitate critical appraisal, and you need to communicate information in a systematic and explicit approach. One of the many systems that's out there is grade. Clever mnemonic. Always go for the good mnemonics. Grade of recommendation, assessment, development, and evaluation. Grade. And the aim of this system was to develop a common, transparent, and sensible system for grading the quality of evidence and the strength of the recommendations. The grade system has been adopted by over 60 groups that create guidelines. When I leave this meeting today, I will be heading to Atlanta to go to the Advisory Committee on Immunization Practices of the CDC that makes recommendations on the vaccines that you give your children and adults. We use the grade system. The grade system has an underlying belief that expert opinions have more bias than case reports and case series, which have more bias than cohort studies and case control studies, and the randomized controlled clinical trial has the least possible bias. So the the data gathered from randomized controlled clinical trials should be the freest from bias. I am from the NIH. We all have to put up slides that we have to apologize for. It all starts with a group of people, commonly known as a committee, and they sit down and decide what problem they want to look at or what thing they want to evaluate. And they decide on what patients they're going to look at, what interventions they're going to look at, what comparator groups they're going to look at, and what outcomes they want to look at. They then have to look at the outcomes. They have to select the outcomes that they think are either critical, important, or non-important. So they decide on what outcomes of these clinical trials they want to look at, and then they rate them to see how clinical. They then take the world's literature and review them, put the results into a flow chart that you get to look at, and then you start to make another series of judgments as you rate the quality of evidence for each outcome. You then get to grade down, interesting use of the word, if you think that there's a risk and bias in the data that you've looked at, if you think there's inconsistency in the results, if you think that the measure that they're looking at is indirect to the measure that you want to look at the imprecision. Can they tell you exactly what they're looking at? And you want to remember that there's a publication bias, and positive trials get into the literature much more commonly than negative trials. The good news is you can also grade up. So the quality of evidence can be graded up if there's a large effect size, and we're going to give you an example of that later. Whether there's a dose response, one of the few things I remember from pharmacology, if there's a dose response, it's probably doing something. And if there are few or no confounders. When you finish that, you go down to grade the overall quality of evidence across the outcomes based, and you do it on the lowest quality of evidence for the critical outcomes. It then goes back to the group. So the group starts this process, gets all the data, goes back to the group, and then they make recommendations. They can make recommendations, and one of the nice things about the grade system is you make recommendations by considering quality, balance, values, and preferences, and revise if necessary if there needs to be a resource. How much does it cost? How available is it? Can we use it at our hospital or center? And then you come out here and you use standardized language. We recommend using, we suggest using, we recommend against using, and we suggest against using. This process is iterative. If necessary, as new data becomes available, this process also often gives you a really good sense of what the information is that is not out there that you want to help you make a decision. And like Napoleon said, all important decisions are made with far too little information. So when we make our recommendations, we often make them with less information that we want, but this at least helps us take the bias out of the recommendations that we want. So this is a system, time-consuming, labor-intensive, but important. And the more important the decision you're trying to make, the closer you should adhere, if not to this system, to another system. For those of you who are unaware, the British Medical Journal, in its December issue every year, puts at least one study in that's a joke. So parachutes used to prevent death and major trauma related to gravitational challenge. A systematic review of the randomized controlled clinical trials. So parachutes used to prevent death and major trauma related to gravitational challenge. A systematic review of the randomized controlled clinical trials. Parachutes reduce the risk of injury of gravitational challenges, but their effectiveness has never been proved by a randomized controlled clinical trial. Yeah. But the grade system allows you to upgrade data without having to go to a randomized clinical trial. This was in not the first, but this was towards the end of this particular article. They looked at the relative risk reduction. They took information from the United States Parachute Association that reported 821 injuries and 18 deaths out of 2.2 million jumps. So they could conclude that even without a randomized controlled clinical trial, that this particular intervention was effective because of the size of the effect size. So if you're looking at a 99.9% reduction, it's probably working even if the trial is not randomized. I work at NIH, I work in the infectious disease group, and there are people who you may be aware, C. difficile has become a major infection, has become a major issue because of antibiotic overuse in departments such as the ICUs, often well-intentioned, but people end up with C. difficile. So then because we caused it by causing an antibiotic and caused by changing the human microbiome, we then treat it with antibiotics because that makes sense, because if you've caused it by antibiotics, you treat it with antibiotics to get rid of the C. difficile. But it's a really specific antibiotic, we tell ourselves. Some brave person decided to reconstitute the colonic microbiome by using fecal transplants. So they would take your poop and give it to me if I had C. difficile. If I give you the usual antibiotic therapy for C. difficile, my success rate after 21 days of therapy, is approximately 17%. If I take poop from somebody you select and give it to you as a colonic enema, my success rate is 90%. Guess what? We're doing the controlled clinical trial to see if it's really effective, because that's what I do. But I can be pretty well sure with those kinds of improvements in the care that fecal transplant is the treatment of choice for C. difficile infection in 2016. So we're now going to finish this up by giving you a small test, okay? You are not going to be graded. So here's a product that recently got approved, and this is the product label in an advertisement. Now, in advertisement, drug companies can only put on what's in the label, and so they basically will show on the label, and I'll highlight the important parts for you now. This is a treatment for hemangiomas in infants. Another case where a very astute cardiologist who was treating children with bad vascular diseases with propranolol noticed that when he started propranolol on children with large hemangiomas, the hemangiomas involuted very rapidly. He reported this in a series. It then got picked up by the pediatric dermatologic community, who then did some case series, and we now have some randomized clinical trials. So on the top are two facts. 80% of hemangioma growth is complete at 3 months. And up to, what does that word mean when you hear up to? Meaning never has it reached 69%. Up to 120 glasses of iced tea. Nobody has ever gotten 120 glasses of iced tea. Of infantile hemangiomas have residual lesions when left untreated. It has proven efficacy, it says, in phase 2 and phase 3 clinical trials. 60.4% had complete or nearly complete resolution by 6 months versus 3.6% of placebos. facts or information. What do you mean when you hear nearly complete? What do you hear when people say that? I think I know what I mean by nearly complete, but I'm not sure what they meant, and until I read the clinical trials, I won't be sure. 88% of patients showed improvement at week 5 of therapy. Again, define improvement for me. So I'm not asking you to be skeptical of everything that comes out. This has been an amazing transformative drug for people with hemangiomas. But be careful when you're looking at information like this. And then it has the safety profile on the bottom. The most common adverse events with this, blah, 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 blah. And then fewer of 2% of treated patients discontinue treatment caused to safety concerns. You might want to know what those are before you start talking to your parents. Also, be careful when people come bearing you gifts. So I'm here talking about the grade system. It's a system I use in 2 different groups that I help make recommendations for. But guess what? The grade system and scale have yet to be externally validated. When you look in a scientific way at the correlation between reviewers, it's not so good. So different reviewers faced with the same information make different conclusions. The good thing about the grade system is there is a process in the grade system to allow you to reconcile those differences. And most importantly, it has never been empirically tested. Do the recommendations that we make using the grade system, are they better than we made using just informed expert opinion? My guess for the last one is yes, but I have no data to support that. So the take-home message. I was fascinated when I got to lovely Nashville yesterday and I walked around. I had a couple of hours of daylight left, that we were so close to St. Thomas's Hospital. Anybody here work there? So St. Thomas, in case you didn't know, was known as the doubting apostle. He was the one who said, I won't believe that Jesus raised himself from the dead until I put my hands in his wounds and I see him with my own eyes. I don't want you to be as bad as St. Thomas in terms of being that unbelieving, but remember to doubt what you're told and say, do I know this? Do I think I know this? And where am I on that particular boundary? So for clinical researchers and scientists and people who are trying to advance public health and personal health, we will only advance our knowledge by collecting data, information, and organizing them without the biases that we all have. And to example that is when, if you're blindfolded and you come up to an elephant, what you think you're seeing will depend on where you go. The people who reach his trunk will think he's got a hose. The people who reach his tail will think they have a snake. The people who reach the side will think they have a wall. And the people who reach his legs will think they have a tree. They're all feeling the same thing. They just don't see the big picture, and they don't have all the information they need. Continue on your work because, as Eleanor Roosevelt said, it's better to light a candle than curse the darkness. Thank you for your attention.